Namaste Betiya, Hamesha Khush Raho Betiya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to continue from the previous lecture of pneumonia. We are discussing about pneumonia because this is the most common and most important disease that is occurring these days and is responsible for a lot of morbidity and mortality among the masses for the whole pandemic, COVID-19. In the last lecture, we had discussed about community-acquired pneumonia. And in today's lecture, we are going to continue with it. So let's start with hospital-acquired pneumonia. In the last lecture, we had discussed about pneumonia. That pneumonia is basically inflammation of the lungs, inflammatory condition of the lungs that is caused by the infection by bacteria and viruses. And it was primarily affecting the small air sacs that are known as alveoli. This is responsible for development of cough, chest pain, fever, and troublesome breathing. Now let's start with hospital-acquired pneumonia. In the hospital-acquired pneumonia, a new episode of pneumonia, when we will call a patient is having hospital-acquired pneumonia. If a patient has been admitted to the hospital and he has experienced a new episode of pneumonia that is occurring at least 2 days after the admission to the hospital. So after the admission of 2 days after the admission of hospital, if the pneumonia has occurred, then we will call it as hospital-acquired pneumonia. Who are the people at risk? The people at risk includes the older people, the patient in the intensive care unit, especially when mechanically ventilated, in which case term ventilator associated pneumonia. So hospital-acquired pneumonia is said to occur if the patient has been discharged from the, if he has been admitted in the hospital and after admission, the pneumonia develops after 2 days after the admission. So then it will be called as hospital-acquired pneumonia. Hospital-acquired pneumonia is seen in cases of especially old age people, patient in the intensive care unit, especially with the mechanical ventilation, in which the cases are termed as ventilator associated pneumonia. There is also another term that is healthcare associated pneumonia or HCAP. It is said to occur when there is development of pneumonia in a person who has spent at least 2 days in the hospital within the last 90 days, and he has attended a hemodialysis unit, received intravenous antibiotics, or has been resident in the nursing home or other long-term care facilities. So when you call healthcare associated pneumonia, when there is development of the pneumonia in the person who have spent at least 2 days in the hospital within last 90 days and attended a hemodialysis unit and received intravenous antibiotics or has been a resident in the nursing home or other long-term care facility. Now, what is the etiology of hospital-acquired pneumonia? The etiology is the gram-negative bacteria. The gram-negative bacteria, which includes Escherichia coli, Pseudomonas, and Klebsiella species. Staphylococcus aureus, including methicillin-resistant Staphylococcus aureus, MRSA, and anaerobes. Now, what are the predisposing factors? Predisposing factors for development of pneumonia, hospital-acquired pneumonia. Now, the predisposing factors includes reduced host defenses, aspiration of the nasopharyngeal or gastric secretions, bacteria introduced into the lower respiratory tract, and bacteremia. So, the first predisposing factor, that is reduced host defense against the bacteria, example corticosteroid treatment, diabetes, and malignancy. There is also aspiration. The second cause is the aspiration of the nasopharyngeal or gastric secretions, which includes immobility or reduced conscious levels. Nasogastric intubation. The bacteria is introduced into the lower respiratory tract. In the lower respiratory tract, there is during the endotracheal intubation, tracheostomy, infected ventilators, nebulizers, and bronchoscopes. The next important predisposing factor is bacteremia. Bacteremia that can occur due to abdominal sepsis and intravenous cannula infection. Now, what are the clinical features of hospital-acquired pneumonia? Whenever a patient of hospital-acquired pneumonia is coming to us, what are the various clinical features with which it can present? The clinical features includes any hospitalized or ventilated patient who develops purulent sputum or endotracheal excretions. There is unexplained increase with oxygen requirement, a core temperature of greater than 38.3 degrees Celsius. So if we have any hospitalized or ventilated patient who develops purulent sputum or endotracheal secretions, there is unexplained increase in the oxygen requirement and a core body temperature greater than 38.3 degrees Celsius. The investigations includes the leukocytosis or leukopenia. So increase in the WBC or decrease in the WBC count. Investigations are similar to that outlined in the community acquired pneumonia. Whatever investigations, the normal radiological investigation, we have to go for chest X-ray or the CT, HRCT. And in the microbial, we have to go through the staining techniques or nasopharyngeal swabs, etc. Now, how to manage a case of hospital-acquired pneumonia? So, for the management part, there is empirical antibiotic therapy that is based on the local knowledge of the pathogens and drug resistance pattern. So, antibiotics have to be given based on the pathogen and their drug resistance pattern, and their variables such as length of hospital stay, since how long the patient is in the hospital, recent antibiotics, and comorbidities. Antibiotics like cefoxitin and gentamicin have to be given. MRSA is treated with intravenous vancomycin. Physiotherapy in those who are immobile or old. Adequate oxygenation therapy is a must for all these things. Fluid support has to be given, and regular monitoring is very essential in such cases. How to prevent a case of hospital-acquired pneumonia? For prevention of hospital-acquired pneumonia, despite of appropriate management, the mortality of hospital-acquired pneumonia is approximately 30%, emphasizing the importance of prevention. Good hygiene, including both the hand washing, is very important. Steps to minimize the chances of aspiration and limit the usage of stress ulcer. Prophylaxis with proton pump inhibitors can be given, and oral antiseptics like chlorhexidine 2% is given. Next, the third variety is the suppurative pneumonia or the aspirational pneumonia. So suppurative pneumonia or the aspirational pneumonia. What is suppuration or aspirational pneumonia? It is caused, and the clinical features that overlap both the conditions, because either there is suppuration or there is either aspiration. Suppurative pneumonia is characterized by destruction of the lung parenchyma. There is destruction of the lung parenchyma by the inflammatory process. So what is happening in this particular variety? There is suppuration and there is destruction of the lung parenchyma by the inflammatory process. The causative organism includes Streptococcus pneumoniae, Staphylococcus aureus, Streptococcus pyogenes, and Haemophilus influenzae. The clinical features of suppurative or aspirational pneumonia includes productive cough with large amount of sputum. So there is great productive cough with large amount of sputum that is sometimes fetid and blood stained. We also have pleural pain in the pleura with high remittent pyrexia. There is digital clubbing, that is clubbing in the fingers for 10 to 14 days. Chest examination usually reveals sign of consolidations. The patient also have pleural rub, and there is rapid deterioration in the general health with marked weight loss. So clinical features includes the productive cough with large amount of sputum, sometimes fetid and blood stain. There is pleural pain with high remittent pyrexia. Digital clubbing for 10 to 14 days. There is also chest examination, usually which reveals signs of consolidation. Pleural rub, rapid deterioration in the general health with marked weight loss. Now the investigations that could be done in case of hospital aspirational pneumonia. Radiological features of hematogenous lobar or segmental opacity consistent with the consolidation or collapse. Abscesses are characterized by cavitation and the fluid levels. Any pre-existing emphysematous bulla that becoming infected and appears in the cavity containing air fluid level. There is culture, blood, and sputum. Now the management part, how to manage such condition. Oral treatment with amoxicillin, co-amoxicillate, oral metronidazole is given. Surgery if no improvement occurs despite of optimal medical therapy. Removal of the treatment of any obstructive endobronchial lesions. The next variety, we come to the pneumonia of the immunocompromised patients. It is the pneumonia of the patient who are immunocompromised, that is, whose immunity is very much deranged by the drugs or disease. The most common causative factor includes gram-negative bacteria, especially Pseudomonas aeruginosa, viral agents, fungi, and bacteria. So, in the immunocompromised patients, the people whose immunity is very much reduced, this is caused by gram-negative bacteria, especially Pseudomonas aeruginosa, viral agents, fungi, and mycobacteria. What are the different causes of immune suppression? Immune suppression is caused due to the following causes. Number one, defective phagocytic function. Number two, defect in cell-mediated immunity. And the number three, defect in antibody production. So the first one is defect in the phagocytic function. It occurs in the acute leukemia, cytotoxic drugs. The second is defect in the cell-mediated immunity. That occurs in the immunosuppressive drugs, cytotoxic chemotherapy. And the third variety is defects in the antibody production that occurs in multiple myeloma, chronic lymphocytic leukemia. Now, what are the clinical features? Clinical features of the pneumonia of immunocompromised individuals. The clinical features includes the fever, cough, and breathlessness. There is cough and breathlessness that can be present for several days or weeks. There is invasive pulmonary aspergillosis. There is fever, cough, and breathlessness that can occur for days or weeks. Invasive pulmonary aspergillosis that causes fever, pleural pain, or hemoptysis and pleural rub. Invasion of the pulmonary vessel causes thrombosis and infarction. Systemic spread may occur to brain, heart, kidney, and other organs. So, in the immunocompromised, there is fever, cough, and breathlessness. The cough and breathlessness can be present for several days and weeks. There is invasive pulmonary aspergillosis, causes fever, pleural pain, or hemoptysis, or pleural rub. There is also invasion of the pulmonary vessels that causes thrombosis and infarction. Systemic spread may occur to the brain, heart, kidneys, and other organs. How to diagnose such condition? The diagnosis is done by invasive investigations such as bronchoscopy, transbronchial biopsy, and surgical lung biopsy after is often impractical. There is induced sputum for obtaining microbiological samples. Now, how to manage pneumonia of the immunocompromised? The pneumonia of the immunocompromised is managed by broad-spectrum antibiotic therapy. Antifungal or antiviral therapies may be added, and mechanical ventilation that increases the risk of nasopharyngeal pneumonia. There are also various homeopathic management. In the homeopathic management for pneumonia, there are a lot of medicines which can be given on the basis of symptom similarity. The most common medicines includes Primea alba, which has dry and painful cough, Drosera that has dry cough twice at the night. We have Hiposulf, in which the cough is dry, hoarse, and worse by cold air. We also have Ipecac 1, with dyspnea and constriction of the chest. Phosphorus is again a very good medicine with hoarseness and tickly cough that can be aggravated by talking and laughing. Pulsatilla has wet cough with thick yellowish phlegm and aggravated by pain. Spongia tosta relieves croupy, barking cough, especially after chill or cold weather. So this was all about pneumonia. In the next lecture, we are going to discuss about pleural effusion. So in these two parts, we have completed the whole pneumonia. But pneumonia is not very simple. You have to go through the book and you have to read all the different types of pneumonia and make sure that you clearly understand and remember all these things. So this was all about pneumonia. This session is powered by digital version 2.0 JP VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, you are free to mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.